Thank you very much, Dave. When you get to be a certain age, you find that history becomes actually much more interesting. And so since I've gradually moved my way into administration and gotten to the point where I really am completely incompetent in the lab, it's very difficult for me to talk specifically about my research, great progress I'm making and so forth. So I'm going to go and talk to you about the history of, give you a historical sense for laboratory medicine, how we arose out of really basic science, and that relationship continues, but also how closely we are tied and how the practice of medicine is tied to us. That one of my chief points is that medicine doesn't exist without laboratory medicine. Remove us, and the practice of medicine as we know it falls apart. Okay? So, let's see. Objectives. These are objectives. Good luck. You will all be tested at the end of this hour. My disclosures, this content is free of any obligations to anyone, but I would like to thank all the people that I've known and worked with over the past 42 years here in the department. I actually came here in 1969 as a student to help Dr. Strandjord set up his research lab. So I was here at the beginning. So to begin with, to paraphrase Rodney Dangerfield, we don't get no respect. And I think we're sort of a hidden specialty that often people don't really know who we are, what we're doing, and we're just down in the lab doing something. I think it's very important that I want to make a point that anytime anyone tries to call you ancillary, I hope at the end of this lecture you will realize we are not ancillary. We are essential. Don't let people get away with that. Okay? It's one piece of legacy I want to leave you with. Okay. So we're going to go through the Age of Innocence, Enlightenment and Rapid Change, and today's Tsunami of Riches. So I actually began in internal medicine. And when I started in internal medicine, we had to do the problem-oriented medical record, which was developed by a fellow named Larry Weed. And all of our notes had to be in this form, where we would have the subjective impressions, objective data, assessment, and plan. I think this has sort of been garbled here at the University of Washington. You'll look at the chart and you'll find it ASOP, which I couldn't figure out what the hell this was, but this is sort of the way the thinking goes here, where you put the assessment before you put the subjective, because nobody waits to find out what the patient's actually complaining about when you do it that way. But I always taught you first talk to the patient, find out what their chief complaint was, get some history, do a physical exam, and start ordering some labs and other things. You need data. Make an assessment and decide on what the patient's, where you're going to go with the treatment. And all of our notes were done in this format and so forth. But I think it's a good construct to think about where we sit, because we sit in that objective level where we're trying to give data to our clinical colleagues and help them move forward. So let's go back about 2,000, 3,000, 4,000 years and think about the subjective. It was pretty much the same as it is today. Patient came in, they got chest pain. Objective, well, pretty primitive. You look at them, and maybe they might look pale, or they might have trouble standing. You would use your senses. You'd smell them. They smell pretty bad. This one's got something's there really. And your assessment will be they're sick or they're not sick. Okay? Now the plan would be, we could bleed them. You could bore a hole in their head, do incantations and a lot of other things, but there was really not a lot of connection with what was going on. And the one thing we could examine was the urine. So urine became a very important element and really the first laboratory examination. Around 400 BC, Hippocrates writes, has a lot of comments about the examination of urine, and has all kinds of things that he writes about and ways to interpret urine. And I just look at the bottom line, but the most deadly of all kinds of urine are the fetid, watery, black, and thick. And this is a really bad sign. And but he really took you through the urines. Galen, considered the founder of experimental physiology, he actually, dissected animals and humans and looked at the relationship between fluid intake and urine output, and he actually described diarrhea of the urine. So a condition where actually people were peeing a little bit too much. And the amazing thing is the findings of Galen from over 2,000 years ago, they remained in effect, and that was pretty much the way medicine was practiced based on Galen's findings for 14 centuries. And mostly what they did was they looked at the urine. Okay? So if you can imagine that, 1,400 years looking at urine. Now here in 900 AD, this Isaac Judaeus writes a book of fevers, and he describes the formation of urine and the value of visual examination of the urine. Now this became an important textbook that it lasted into the 17th century. You can see we're making a lot of progress. We're examining, and then we got published books on urine examination. It became such that the Code of Jerusalem, I think this is from the Crusaders, the failure to examine the urine could result in public beating of the physician. So this was really a requirement. Now, the faith in uroscopy was such that most of the time you didn't even have to see the doctor. You just had to give a specimen, give it to the apothecary or whatever, and they would deliver it to the physician, and the physician would make an interpretation and decide what to do with the patient. Okay? Now, there's an interesting story. This Thomas Willis is one of the first people that says, "Wait a second, this is craziness." So there's a story of a shoemaker submitting one of these flasks of urine for interpretation, and he looks at it and he dumps it in, he says this is coming from a bootmaker, a shoemaker. So he thinks this is actually, he's reached the point, this is ridiculous, and I have to see the patient. So he pours urine back into the boot, and he sends it back to the shoemaker and says, if you can tell me what kind of boot I should wear from this boot filled with urine, then I will interpret what I received. And so this is sort of we're starting to make a break with this, this way of looking at things. The small changes start seeing the introduction of additional devices like the microscope, thermometer, and now we have some measures that we can actually rely on. And so I'm going to take you now through we're going to talk a little bit about chemistry, hematology, microbiology, in terms of how these areas evolved. And I apologize for the other area, immunology, coagulation, transfusion medicine, and so forth. We just don't have time to cover everything, so, but we'll start with chemistry. The dawn of clinical laboratory testing. So way back in the 1600s, Van Helmont introduces gravimetric analysis, but he doesn't really apply it to medicine. Deckers observes that urine would precipitate when boiled with acetic acid. So we're doing something a little different than just looking. We're actually taking and we're starting to manipulate it. And Willis notes the sweet taste of diabetic urine. There's a certain kind of urine that's sweet. It's associated with these people that are peeing a lot. We don't have a lot of things to help them with, but we know that. And we can actually distinguish this between another condition where they're peeing a lot, diabetes insipidus. So we're starting to classify. And this is a major thing that's starting to occur in medicine as we start some sort of laboratory testing, some way to distinguish one thing from another. Because we're not going to be able to treat anything until we start dividing stuff up. Now, phlebotomy. Phlebotomy is a big thing for us today. But back, in the 14th, 15th centuries, leading up to that time, phlebotomy was primarily a treatment. This was not, blood wasn't drawn to actually analyze it, although people started, basically about in the 14th century, it looks like, people started examining the blood that was drawn off and looking how it clotted and so forth. But phlebotomy was not done. It wasn't done for diagnostic purposes. It wasn't until about the 17th century, John Locke, the father of liberalism, suggests chemical analysis of the blood might yield information of medical diagnostic and management value, and he encouraged his friend Robert Boyle to undertake analysis of normal blood. So Robert Boyle, if you can remember, anybody ever hear of Boyle's law? PV equals nRT, or P is proportional to 1 over V, the relationship of pressure of a gas to its volume. So that's Robert Boyle. So he began experimenting. And he comes up with properties of, physical properties of blood, the specific gravity, temperature, taste, does some chemical analysis of it. And looks and he can thick oil, clear liquid, phlegmic liquor, volatile salts, caput mortem, I love that one. It's useless residue after you dry or boil everything off, and some salts. Then the English physicist in Houston discovers a coagulable lymph. And this is really what we will learn is fibrinogen. Matthew Dobson proves the sweetness of urine and blood in diabetes is caused by sugar. It's not caused by aspartame. Okay. Francis Home developed the yeast test for sugar in diabetic urine. So, we can actually add a little yeast and we can measure the sugar. Clinical diagnostics came into vogue in the 18th century. Heart rate, blood pressure, chest percussion, temperature. I mean, these are all things, when you go to the clinic today, this is how we measure meaningful use, is the doctor does these tests, okay? So they were introduced in the 18th century. And it's very reassuring that this is how we measure if the doctors are doing enough. and Dave Chu will attest to that. Brown Languish, in his new practice of physics, talks about chemical analysis of blood in various types of fever, lymph, volatile salts, oil, caput mortem again, and so forth. Davies writes an essay to promote the experimental analysis of blood in 1760. He comes up sort of empty-handed. We can do some of the analysis, but basically we can gain no particular information from this method of inquiry. So even though he analyzed the blood and came up with a number of components, wasn't sure that meant anything. Because the problem is we can measure things, but if there is no clinical application, okay, so very nice. And sort of the question we always ask if somebody wants something done, what are you going to do with the results? I'm sure that this is a common thing. It should be amongst our residents when they get these crazy requests. What are you going to do with it? So there really was no further advances in blood chemistry until the turn of the century. They really didn't have the reason. They could do some analysis, they could do some chemistries, but they really didn't have a lot they could apply. Lavoisier, father of modern chemistry, moved chemistry from qualitative to quantitative methods. I think this is a very important change. I mean, he is the guy that's given credit for realizing oxygen is involved in combustion. He actually names oxygen and hydrogen, helped develop the metric system. But he was also, when you read about these folks, they did a lot of things. They weren't focused on medicine per se, but medicine was just a side. Let's do a little bit of that too. At the same time, we're doing all these basic chemistries and so forth. By 1800, quantitative methods of analysis were leading to a rapid progress in chemistry. Okay, blood chemistry included water, albumin, muriates of potassium, sodium carbonate, potassium sulfate. Albumin could be broken down into its components, but there was no immediate application in medicine. Okay, medical diagnosis and treatment were limited to the appearance of blood. Did it look dark? Did it clot fast? These were very simple things. So even though we could do some analysis, really wasn't being used. Proteinuria. How many of you have heard the term dropsy? There's about 6 hands go up. Okay, it's interesting because I'm going to mention this. I'm going to mention Bright's disease. When I was I'm so old. When I was an intern, when I was a medical student, you'd take a patient's history and you'd get family history, and grandma had dropsy. Grandpa had dropsy. And it was like, dropsy is basically edema. Okay? They figured it had to do with dropsy comes from hydrolysis, or some, I can't remember what the term is, but it comes from water. And so this is an accumulation of water. Anyway, so people started, they would look at patients with dropsy, and they found some of them had serum in the urine, or really protein. John Blackwell describes proteinuria and dropsy, but the problem is they don't make the link. They describe what's there, but the link hasn't been made. What does it mean? Okay, you got patients that have basically protein in the urine, and they have this condition. Okay, well, that's really nice. It took Richard Bright. Now this is another one. I would hear patients. Bob, did you ever hear a patient had Bright's disease, or a grandfather or something? How many else in the room? Yeah, like Ferric, I know. Yes, we're a small group now, but when we take histories, you'd have patients whose family history there was Bright's disease, and Bright's disease goes back to Richard Bright in 1827 in his reports. He writes a report. He makes the association. He's looking at cadavers and so forth. That there actually is kidney disease in these patients. And he starts measuring specific gravity, urea, the salts, and urea normally, urea is about 4% of urine, and in his measurements, and the salts were 2%, but they were reduced in these patients. And they had albumin that might be present in enormous quantities. So he's describing patients that are losing proteins and are putting out otherwise, they're having dilute, low specific gravity and so forth. But he makes the association with these other researchers didn't make the association. It's actually disease of the kidney that's happening, that he can find pathological changes. And this allowed people then to go and investigate kidney disease and try to associate it with what's appearing in the urine. So here's laboratory tests, protein, examining the urines and actually making a determination that there's a cause and effect here. And maybe if we can figure out treatments, that's the ultimate goal, we can actually, doing these measurements is actually going to make a difference. William Prout, in his inquiry into the nature and treatment of diabetes, calculus, and other, he was the first one, in terms of his overall research, to suggest atomic weights of all elements were multiples of hydrogen. And he actually purified urea, first one to divide organic substances into groups of carbohydrates, fats, and proteins. He discovered HCl was in gastric juice. And he also defined what you needed in a clinical lab: litmus paper, watch glass, 2 small pieces of plate glass to distinguish mucus from pus, a portable hydrometer, and a blowpipe. A few test tubes, maybe bottles of ammonia, potash, and nitric acid. So he actually came up with what you need to have in a little medical lab. Okay, but he was really a basic chemist. Gabriel Andrel was the one who really introduced, let's start measuring things. Let's get away from just urine examination. I want to examine blood. And he's looking at fibrin, red cells, solid material in the serum and water. He describes low albumin associated with the dropsy again, and the albuminuria. But he also sees the same thing in famine, in patients that are starved, that they have low serum, low blood albumin. And he also goes on to divide febrile diseases into 2 groups, one where there's reduction in fibrin, that includes typhoid, smallpox, measles, scarlatina, and increase in fibrin, those with more substantial buffy coat, and internal inflammations like pneumonia, rheumatism, abscess, and erysipelas. So we're starting to see medicine, by laboratory medicine methods, by clinical pathology, being divided. We're starting to categorize different states. This is very important because what we assume always has existed, this is 1843, less than 200 years ago. We hadn't divided. All the things we know, all the diseases we talk about today, they're just starting. And it's in the lab that they're making these distinctions that are going to allow the clinicians, the pathologists, other people to actually come up with different disease categories. Bence-Jones, 1847, described a peculiar protein in the urine, precipitated in urine by alcohol, but not by boiling with nitric acid. As the urine cooled, the precipitate precipitate that had fallen redissolved when he boiled it. And at post-mortem, the patient, of course, ended up dying. Post-mortem, the patient was shown to have softening of the bones. Now, you all know what Bence proteins are. Multiple myeloma. And these are your light chain kappa, so forth. So didn't know what was actually going on, but started describing something that was occurring that he could distinguish in the urine. It leads back to let's go back and look at these things. And over the course of time, we end up coming up with a disease entity. colorimetric methods beginning in modern clinical chemistry. Here's a colorimeter, and it was employed for doing hemoglobins in 1894. Otto Folin used it to do a determination of urine creatine in 1904. Here's this is one in the department. It's in one of my boxes at Harborview. I have no idea which box it's in, but luckily a long time ago I took a picture of it. This is a Dunning colorimeter that somehow made its way to my office. But basically what you had is a whole series of tubes with colored fluid, and you could actually make a quantitative analysis of something, some chemical reaction or whatever, by comparing it, putting it into one slot and comparing your sample. That was a big breakthrough, the colorimeter. It's, you know, sort of the early mass spec. But there continued to be rapid advances in clinical chemistry. Folan was I have to mention Folan because he was originally from Minnesota. He came from Sweden, then immigrated to Stillwater, Minnesota, went to the University of Minnesota briefly, eventually became the director of the clinical lab at research lab at Harvard. But he's a Minnesota guy. Figured out precipitating proteins with sodium tungstate and sulfuric acid to give protein-free filtrates. And in 1920, developed a classic glucose method. Keep in mind, it wasn't, sometime in 20 to 21, Banting and Best were able to isolate and purify insulin. So the need to actually analyze and come up with a good method for doing glucose was just starting to hit as we're starting to understand diabetes. And so hand in hand, we went with treatment. Microscopy. So we'll take you back a little bit. 1676, Dutch businessman and scientist, and Antony van Leeuwenhoek, Hoek, sort of an umlauted with an OE, okay. Leeuwenhoek, father of microbiology. He was the first one to observe bacteria and microorganisms with a microscope. Examined blood microscopically. He examined blood under a microscope and saw small round globules driven through crystalline humidity of water, is how he described it. He made these findings. This is all very well and good. What happened? Did we have a blossoming of microbiology, clinical microbiology at this point? No. It's going to take another 100 years or so before there's any application for this. Kircher sometime in the 1600s, Jesuit priest in Germany, probably the first to use a microscope to investigate a cause of disease. He showed that maggots and other living creatures developed in decaying matter. Observed that blood of patients from the plague contained worms. And what he was probably looking at was white cells in his 32-power microscope. I'll tell you look at Leeuwenhoek's microscope and you wonder how the hell he saw anything. But the clinical lab really incorporated a microscopy between the years about 1840 and 1890. And just like when we started developing the use of molecular techniques throughout our labs, this was a lab unto itself. So that anyone who wanted to apply microscopy did it in the microscope lab. So it really included the hematologist, parasitologist, bacteriologist, all these histologists, all these functions really. It's something you do. Here's the technology. It's the microscope guy takes care of it. So Alfred Dunn was one of the people who really started popularizing it in Paris. He was so loved the microscope that he started having little classes in the evening where he would examine blood and show it to his students. He described what today we would recognize as leukemia, but his real claim to fame was looking at breast milk, and there was an ill prince, and he looked at the breast milk from the, because they were willing to look at anything in the microscope. So they looked at breast milk and discovered that there was something wrong with the breast milk. And he told them, and they got a different wet nurse, and the prints got better. So he was a miracle maker, and that was a real help to the development of clinical microscopy. But this went on. Here's a case of John Hughes Bennett, one of Dunn's students. He sees a patient suffering from syphilis. He examines the urine and saw spermatozoa. And talks to the patient, history of involuntary seminal emissions. So, of course, the logic of what to do, as I said, it takes a while for people to adapt the clinical lab, and we find things, but it doesn't mean it's always the right thing. The treatment is always right. So he gives the patient a treatment of beefsteak, beer, and tonics. And 6 months later, the patient's actually doing better. So again, another success story, and another reason to continue to pursue this technology. 1845 describes a case of an abnormal increase in white cells in a patient, and together with Rudolf Virchow, father of modern pathology, is credited with discovering leukemia. And we'll go into that a little later. 19th century brought a lot of technology. Stethoscope, 1816. Ophthalmoscope, 1847. Laryngoscope, sometime in the 1800s. More refinements of the microscope became a much more useful tool. X-ray, 1895. EKG, 1872. So all these were new technologies being adapted for physical exam, for helping the physicians actually come up with diagnosis and treat the patients. So we're really moving along. Clinical microbiology. Go back to 1840. Jacob Henle. Jacob Henle was a anatomist, physiologist, and pathologist. He named a lot of stuff. When you think of even the kidneys, Henle's loop. This is the guy who did this. But he was thinking. I mean, he didn't. He had the microscope. He's trying to decide what to. He's looking for causes of disease, and he gets on this idea of bacteria. And let me just read this quote. "We must hold that the cause of the miasmic contagious diseases is a material endowed with independent life, which can reproduce itself after the manner of animals, plants, can increase by assimilation of organic materials and growing parasitically on the infected body, can give rise to symptoms of the special disease." He looked in his material. He looked in the material that he had, the autopsy material and so forth. Couldn't find anything. He was really trying to find bacteria. He believed bacteria caused disease, okay? But he couldn't find the evidence. But he assigned he talked to one of his students, Robert Koch, who you may have heard of, who's credited with the criteria of showing a relationship between causative microbes and disease, Koch's postulates. Koch actually came through and did the work that Henle had suggested. But it's a slow progress. We look at it, 1849, a couple of researchers, Devane and Pollander, see bacteria in cow's blood infected with anthrax. Leuckart, Virchow, and Zenker work out pathogenesis of trichinosis. In 1862, Pasteur invents the healing process to kill most bacteria and molds. 1867, Joseph Lester publishes in The Lancet his discovery that carbolic acid will decrease the incidence of gangrene in his patients. And finally, in 1876, Robert Koch proves Devane's bacteria as the cause of the anthrax. So they made these associations, but they hadn't really proven. It took Koch to do that. And now it's also interesting to look at the literature. 1865, up till 1865, there was no reference to bacteria in The Lancet. Okay? So we think of all these bugs, and we had a great talk by Ferrick a couple weeks ago, and all the things we know today. 1865, not that long ago. They didn't have any articles. Nobody had written anything, let alone viruses. 1875, the Pathological Society of London was debating the question, the germ theory of disease. This was still up for debate. Koch had really come up with, really proved that the germ theory is real, okay? But back in England, let alone the United States they were just recovering from a civil war. And back in England, they're still debating whether the germ theory is real, okay? They still, there was still a lot of people who didn't believe it. And anyway, the folks in Germany, they just went forward. They just do it by the book, and they already proved this, so they just kept moving. Koch develops a gelatin medium on a glass slide. It's a little, first he observes the colonies growing on potatoes. Okay, you can slice open a potato, and a couple days later you got some, oh my God, he's got these little colonies growing. He ends up developing gelatin medium for glass slides, does some refining of that, and one of his students, Julius Petri, he comes up with a modification. He puts it in a little glass dish. It's actually much easier to use, and so that's where we get the Petri dish from. And finally, in 1882, Koch's clinical bacteriology becomes legitimate by Koch's discovery of tuberculosis bacillus, TB. 1882, also at the same time, Ehrlich works on improving the staining methods for TB. And this was really an important event in the development of microbiology, because now we had really, we had the symptomatology, people are trying to make the diagnosis, but now if we really can hone it down, this is the bug that's causing it, we can stain for it, we can show it exists. This was a real breakthrough in terms of microbiology, because before it was all conjecture and so forth. But here it was, we could show it in the tissue, we could actually show it existed. 1884, Christian Graham introduces another staining method for bacteria, so you can separate the little balls from the little rods, the ones that are red, the ones that are blue. But he didn't appreciate for years the ability to do this, okay? Because he was looking for a way to stain tissue and make the bacteria show, okay? So it wasn't so much looking at it on a slide and really differentiating the little balls from the little rods. But this was, again, today we're using the Gram stain, 140 years later. Richard Pfeffer, he added blood to agar. And now we could grow some other things, like H. flu. So we continue to do these things, adding McConkey's media. There's the whole series of these started happening. And we can see that now we have, we really got something to work with. Antibiotics. The exploitation of clinical was really dependent on treatment. Until we had something to treat with, you make the diagnosis, and this is really interesting, but unless we could really eliminate these, that was the key to going forward. So Paul Ehrlich developed the first antibiotic chemotherapy. So his idea was, if I'm figuring out all these stains that actually stain different cells, maybe I can figure out something that maybe makes something that will kill bacteria like arsenic. Let's see what I can concoct and see if they can actually go after these cells. The same, trying to use what he's learned from staining to develop an antibiotic. And he comes up with a organoarsenic that was called salvarsan, and that was itself was a big breakthrough. Alfred Bertheim went on to discover a series of arsenic-derived synthetic antibiotics. 1910, Ehrlich and one of his associates, Sakachihiro Hata, announced the discovery of salvarsan, and its utility in treating syphilis. So now we had an antibiotic. So this is really the first antibiotic, and it really made all this work identifying these bacteria, isolating them, figuring out how to culture them, and so forth. Now same guys, Paul Ehrlich and company, they developed the first antibiotic. Then we've got a series, we've got the sulfonamides, penicillin, and actually there's a whole series of researchers that noticed that there's different kinds of penicillins that, William Roberts notes that the mold Penicillium glaucum used in some types of blue cheese prevented bacterial contamination. So they're seeing the fact that there seems to be a war going on between bacteria and fungi. But it wasn't until Fleming observes, the real breakthrough is penicillin chrysogenum, inhibiting the growth of bacteria on one of his culture plates. And he purified, this was later purified in the 1940s, and we end up with penicillin. Again, another drug that can actually treat the bugs. So this is the evolution of medicine. Without laboratory medicine, without clinical pathology, nobody's going anyplace. Okay? Remember that. Now I just threw this one in because this is University of Washington. This is from an article by Bauer, Kirby, Sherris, and Turk. This is the antibiotic susceptibility testing by the DISC method. Okay? This was the Kirby-Bauer test, was developed here at the University of Washington. Those are the 4 people that were on the paper. And Dr. Sherris was actually the first director of our microbiology lab when the department became a department. Hematology. Unuk, as I said, describes some small round globules. And it took a while to progress and figure out anything. In 1840, they looked and they said, oh, look, it's the disc-shaped nuclear red cells. There's some other things in the urine. There's red cell nuclei floating around, lymph corpuscles, albuminous particles. In 1842, Addison identified pus cells with the white cells of blood. So the cells you could see in the pus, actually, he was the one who successfully made the connection. These are the same cells I'm seeing in the blood. So these are big, to you might, this doesn't seem like a big deal, but this was big. Anemia. Again, another avenue to travel down. This is in the 18th century. We're now able to say, oh, look at this. Some of the patients, when they bleed, the amount of red cells in the blood is less. On the other hand, sometimes it's associated with malabsorption. There are other diseases, cancers and so forth. They were actually started honing in on, as they were able to look at the blood and determine the number of red cells. That was actually making a difference in terms of our diagnosis. The actual estimation of this took the development of cell counting chambers and methods. And so the first one was 1852. Carl Virology published the first method for counting red cells using a capillary. And here's a number of different different counting setups that were developed. And we go on and on. Of course, Paul Ehrlich pops up again, staining blood films, and he actually starts developing more classification of the cells, anacytes, nuclear red cells, neuroblasts, as well as the recognition of leukocytes as really distinct cells, which leads us into leukemia. For this one, we have to go back to 1839. And we're Dunn noted an increased proportion of white cells, but didn't pursue it very much further in one case. And then we get Craigie, who describes a 30-year-old man admitted with general feebleness and enlarged spleen, and who dies a couple months later. He's got a very large spleen. It's pale, semi-fluid pinkish blood, and notices the globules of purulent matter and lymph when looking at the blood. There's another case that comes in 1845. J.H. Bennett performs the autopsy on that one. And it's from this that Virchow, along with his own case, a 50-year-old woman who died with white blood and what he termed white blood and leukocythemia, that we really start getting into the period where they're starting to see a lot of white cells. And it's Virchow who coins the term which we call leukemia today. And so in 1847, Virchow devotes a long article to the discussion of this new disease, which he was able to distinguish, and he was able to distinguish lymphatic from myeloid cells, and it took a few years to be accepted. So it wasn't, he comes up with this idea, but it's not that right away people agree with it. Leukocytosis, likewise, he actually discovers that, you can have high white counts, but it doesn't always mean they have leukemia. This is not something that's going to kill them. We have different reasons for it, and so that again is Virchow. And Paul Ehrlich, as I said, he comes up with clear distinction between working on stains and really comes up with there's difference between the lymphocytes, large mononuclear white cells, transitional forms, polynuclear leukocytes, eosinophils, and mast cells. Okay? 1879. Not that long ago. So we could go through stories like this in coagulation and immunology and transfusion, a lot of other places. I think the bottom line comes down to what old Doc Evans from Minnesota had to say, that in laboratory medicine, we look a little bit. That's microbiology and urines. We've seen a lot of the looking. But that led us into, we grow some stuff, mostly in microbiology. And the rest is chemistry, whether we call it coagulation, immunology, transfusion, or whatever. So I've sort of touched on your areas. Sorry, I guess that's the cheap shot, but 20th century. Getting into the 20th century, the big break in the 20th century is the Flexner Report, where he really criticized the way we're getting educated. We got to bring science into the education. Said we got to reduce the number of medical schools. It's just catch as catch can in terms of medical schools. Train people in a scientific manner. Give medical schools control over the instruction that occurs in the hospitals, and strengthen regulation. It was the application of this report that really changed medicine. It changed at the turn of the century. What was going on in this country? Who is the real leader in terms of internal medicine? It was William Osler. Have you all heard of Osler? He's described as the father of modern medicine. And at the turn of the century, he went on a tour. He was out in Europe studying what they're doing, and that's where all the advancements were being made in the clinical lab. He comes back, he's so excited about this. He talks his hospital, or some donor or whatever, into giving $10,000 bequest to build a lab at Johns Hopkins. He's got to have a lab. And after that point, as he went around and would visit places, he would always look, let me see your lab. This became very, very important to him. So in a way, if we look at it, William Osler may be, and in fact, I've seen a couple of authors that have said that he really should be considered the father of clinical pathology. That was he was really the guy pushing. I mean, he's so famous for what he did in terms of organized, internal medicine, organized medicine. But he was the guy who really wanted to, he saw, if you're going to do medicine, you have to have a modern lab. Okay? So in his Principles in Practice of Medicine, I'm going to go through, in the 1892 edition, he said you had to have a lab, clinical lab that could do hemoglobin estimate, RBCs, white cells, parasites of malaria, simple UAs, microscopy of sputum for tuberculi. By the 1912 edition, I mean, he keeps adding things. By the 1912 edition, and this is because of the advances that are going on in medicine. Spirochetes and syphilitic lesions, Wassermann reaction, osmotic fragility, and a crude glucose tolerance test. So we see an evolution of laboratory medicine occurring in his books in terms of what he's making a point of. These are the things you should have in your clinical lab. So the organization of laboratory medicine beginning in the 20th century, we have the American Society of Clinical Pathology. Early in the 1920s, CP was in its infancy and generally practiced by internists, and some PhDs, but barely recognized by other physicians as a specialty. 1922, Ward Burdock from Denver gathers his colleagues at the AMA meeting in St. Louis. May 22nd, 39 physicians meet at the Missouri Baptist Sanatorium to achieve greater scientific proficiency in clinical pathology and maintain the status of clinical pathologists on an equal plane with other specialists. May 23, over 100 physicians meet to approve the constitution and bylaws of the ASCP. This is basically an organization that was formed out of internal medicine. Okay? It came on the heels of an AMA meeting. So this is where the impetus was, and it really follows because of our relationship that we've had with the clinical practice of medicine, that this is where the big push to have organizations within our specialty. Grand proposal, jumping way up to Jerry Evans. I have to mention this because I came from Minnesota. He presented the dean of the University of Minnesota an 80-page proposal, which I actually have a copy of, to create what became the first Department of Laboratory Medicine in the United States. Our growth is our own specialty. The techniques and basic sciences applied to the enlightenment service and research has lagged compared with the rate of innovation and development in other departments. A laboratory that is standing still is a laboratory that is going backwards. This would apply at any time. This is not any time, but a period of logarithmically increasing volume and importance of technical procedures. We're living in the golden age of medical discovery. Medicine has advanced more in the 50 years of the first 50 years of the 20th century than all preceding time. The pace is still accelerating. Great discoveries in fundamental fields have stirred the imagination of clinical investigators and basic scientists. Medicine has been made over. It is from the fundamental fields that new things will come. Progress in clinical medicine will be achieved in large measure through the use of increasingly complex laboratory equipment and procedures. So that was his proposal. Then in 1965 was the development of the Academy of Clinical Laboratory Physicians. Ellis Benson, Ernie Kotlov, Frank Queen, David Seligson, John Strumford, and George Williams meet at the ASCP annual meeting to discuss the problems of teaching laboratory medicine to medical students and residents and physicians. And in 1966, they found ACLIPS, with the central idea to promote the education and training in laboratory medicine. Here at the University of Washington, in 1968, their clinical labs were shared by 4 departments. There was clinical chemistry and biochemistry with Alex Kaplan. Microbiology was John Sherris in the Department of Microbiology. Hematology was shared, Dr. Clem Finch in the Heme Division of Medicine and Cecil Hoagie in pathology. the King County Hospital, which is now called Harborview, the clinical laboratories were two faculty members in pathology, and hematology, Robert Hillman, heme division from medicine. And so it was these folks that Paul gathered together when he came to advise the University of Washington on the formation of our department. And the clinical microbiology lab at U represented a national standard of excellence. However, the remainder of the laboratory service had major problems. For example, surgery was canceled in July 1969 as equipment failures made it impossible to obtain electrolyte determinations. Many instruments provided by the hospital were outmoded and in disrepair. Staffing on the evening at midnight shifts and on weekends was particularly weak. At the University Hospital, for example, there was only one technologist available for evening and midnight shifts for all laboratories. She routinely worked a double shift, and when she was taking a shower in the hospital, no laboratory service was available. So he developed a paper for what he was going to do, and this was his design of the functional design of the department with 2 hospitals, specimen receiving and transportation, very important, but his concept was the baseball field, baseball diamond. So you'd have the processing at home plate, all the rapid testing was gathered in the infield, and in the outfield with those tests and procedures that could be done at a more leisurely pace. And this is an example of the 1971 Virology Orders. This was the complete charge schedule for virology. Okay? Kind of modest by today's comparison. Here's an SMA-12 failure. It's done it again. Our SMA-12 has completely quit. Well, anyway, it quit. And she sent out this note. This was posted in the wards. Here's our early multi-channel analyzer in chemistry. Residency program in 1969. ClinPath residency was struggling as coordination of training and using laboratories under the direction of several different departments was difficult. Most of the residents in anatomic pathology went elsewhere to obtain training in clinical pathology, and only one resident decided to sign up with the new department. We inherited a med tech program that was actually in pretty good shape, and it's now one of the oldest medical technology or MLS programs in the country. And with that, I better quit because I'm beyond my time, and so there's very little time to ask questions. So I do have more. I skipped a lot, but I'll tell you, it was a lot of fun putting this together. So, any questions?